welcome everyone to our webinar on how patients struggle with treatment, the cost of non-adherence and why it matters. It's well known that many of us don't follow guidance from our healthcare professionals for a wide range of different reasons, and this impacts our own health, but it also impacts the healthcare system in missed appointments, emergency hospital visits, treatment escalations. And for those of a systems mindset, this points to a gap between the needs of the system and the needs of the patient, which we really need to address if we're going to have an efficient healthcare system which supports patients to integrate their healthcare activities into their other life priorities. The first step in solving any problem is to understand it, so I'm delighted to welcome three great speakers with perspectives from patients, healthcare research, behavioural support, who will provide us with their insights into the problem and just possibly help us to start thinking about what's needed to solve it. If you have any questions during the webinar, please put them in the Q&A and we will try to answer as many of them as we possibly can, many as we have time for. So let's get started, because I'm sure you're more interested in them than in what I have to say. So our first speaker is Stefan Gijssels, who is a patient advocate across multiple different disease areas. As a survivor of metastatic colorectal cancer, Stefan co-founded Digestive Cancers Europe in 2018, and he also serves on the board of Alzheimer Liga Vlaanderen and is a member of Prolong, the Lung Cancer Association. Stefan has authored a book on the importance of integrating the patient perspective in medical practice and health policy, and since January 2021 he's chaired the Patient Expert Centre in Belgium, which trains members of patient organisations to become patient experts in their own disease area. So I'm delighted to welcome Stefan as our first speaker to share his experience.
Thank you, Claire. I'll upload my slides. Thanks for having me, and thanks for putting the patient first. I think that's always welcome. We're an organization that's been set up by patient organizations in Belgium to make sure that the connection between patient organization and the professional partners is much more aligned. And to develop that, we created this kind of 360-degree perspective on how healthcare should be organized. It's a perspective in which the medical perspective and the patient perspective are equally important, both at individual and collective level. I mean, we're all familiar with the top left quadrant. That's the treatment, the diagnosis, treatment, supportive care, and follow-up. But if we want this to be optimal and really matching the situation of the patients, we have to take the individual patient perspective into account, listening to the patient, integrating the life goals and life expectations of the patient, understanding the context of the patient, socially, financially, in terms of health literacy as well, whether or not the patient has experience with the disease in the family, but also whether they can organize things practically at home. Do they live alone or do they live in a family? What's the situation at home? Are these people able to deal with the bureaucracy and the paperwork of being ill to get reimbursement and access to services? And can they navigate the system? Are they aware of all the services and that they are entitled to, organized by governments or municipalities or other places? And so the more the treatment program is actually adapted to the life of the individual, the better the adherence will be and the better the outcomes will be. Our role as patient organizations at the bottom right as a collective voice of the patient. So we support individual patients to help them dealing with their disease, coping with the disease and the treatment. And in doing so, we capture the collective intelligence of patients with that specific disease. We identify needs, identify problems, but come also with creative solutions. And then we advocate to the health policy part, which is at the bottom left of the quadrant. There are 4 solutions to lack of adherence, at least from our perspective. First of all, technology from the very beginning needs to be co-designed with patients to make it user-friendly. I will not go into that part because I think the other people, presenters will also address this. Secondly, treatment plans. So the overall concept of the design of a plan needs to be co-designed with patients. Patients also need individual support and guidance, and you also need, and that's what we're advocating for, to have population health management plans by type of disease, so that you get the necessary feedback about things going well or going less well. I'll give one example of the participation of a treatment plan. This is a project that was designed for psoriasis patients in Belgium at the University Hospital of Ghent. So they changed actually the entire patient pathway for the treatment of psoriasis. And they started by identifying 21 patient-relevant outcomes. Based on that, they took a lot of time to listen to patients from the very beginning, after diagnosis, much more time than was invested in the past. And by doing so, they understood much more about the complexity of the environment and context of the patient. And interestingly enough, because they took so much time to understand, the treatment plan was adapted to the individual patients. And there was much better adherence and outcomes and less medical interventions, and as a consequence, also lower cost in the treatment. So better outcomes, lower cost, thanks to integrating the voice of the patient from the very beginning. Second is that it's also important within any disease treatment plan to look at the shared decision-making of the patient. Listen to the patient, as I just mentioned, but also give the patient time to inform themselves before a treatment plan has been approved, which means, in our perspective, let the patient talk to a patient organization to understand what can be expected from the disease and the treatment, so that they have more knowledge, more information before accepting any treatment plan and co-designing together with and co-deciding together with the medical team what is best for them. And then, of course, and I think this is critical, give the patient an active role in the treatment plan. They don't just undergo a disease, they participate in the optimal care they give themselves as well. In this context, we also advocate for the use of a patient bio, where all these aspects are integrated and also integrated in the electronic health record, so that any practitioner looking into the patient electronic health record immediately can see what the level of health literacy is, what the eventual, if possible, religious belief or taboo situations are for the patient, and other practical things that are important to them. And also to add a checklist with the required patient information to manage the disease, both clinical and non-clinical. We always assume that the patient is self-reliant. And so organized care consisting of people and technology offers this self-reliant patient technology in a certain context. In reality, of course, when people are involved, the systems are fallible. So we have fallible people at the organized care, but definitely at the patient level. And I think it's important to take that into account. People are people. They live in different contexts with different levels of knowledge and health literacy. Some figures from Belgium: 33% of people living in Belgium have a low level of health literacy. 52% of patients feel that they have not received enough information from the medical team. Patients understand only 50% of what they are told by the specialist, and patients forget 50% of what they have understood. So not much is left after consultation. And as a consequence, 50% of patients in generally do not adhere well to their treatment, or to take their treatment not correctly. And so that's why we, as patient community, try to help. So it's a triangle. It's not a bilateral deal between the organized care and the patient. We can help. We can assist individual patients. We can give them support. We give them guidance. We can help them navigate, just to make sure that the outcome of the treatment is as best as possible. I'll give some examples of supportive care. The first one is nothing to do with medication or treatment, but it's a survey that showed that patients with dementia and their family who get individual support from volunteers usually and generally go 557 days later to a residential care center than patients who do not get this type of support. This is just an example. The gains of this are huge because of the huge number of patients. Another example is patients with bipolar disorder who get antipsychotics. When they get weekly calls from the volunteers, these patients have on average 18.6 days in hospital compared to patients with who do not get this type of support. They have 38.9 days in the hospital every year, again, leading to a lot of human misery and loss of taxpayers' money. We also worked in the last few years with the King Baudouin Foundation on interesting report that comes to the conclusion that patients who get support have faster and better health outcomes. I will not go into the detail of that, but I'll share you the link if you're interested. It's unfortunately only in Dutch and in French, but it has the merit of existing. And then maybe the last thing is that once you have a treatment plan, you have to quantify this. You have to make this a population-based health management plan. And I kind of simplified it a little bit in this patient pathway. So the color coding is obvious. Dark green is the best practice and dark red is the worst practice. And the white dots are the averages. So you can identify together with the specialists, policymakers, and patients what the key performance indicators would be in the entire treatment pathway of a specific disease. And you can identify, for instance, the number of patients with good lifestyle choices, the quality of the health literacy on the patient population, participation rate in screening programs, or the number of patients in the case of cancer, as this is the case, number of patients diagnosed in stage 1. But critically, you can also check the treatment adherence of the entire population within this type of disease. And you can compare where they are treated, in which hospital they are treated, and see whether there is any difference between the hospital and the treatment adherence. So these quantified data allow to provide feedback to the healthcare system to make sure that they adjust where needed. And what we also advocate for, apart from having plans for every disease, is also to have disease observatories consisting of specialists, patient organizations, and other experts to convene annually and to identify the statistics and to verify whether any course correction of the plan is needed. As I said, this is in reality a lot more complex than these 20 dots. You can have 30, 40 dots. It's a model that's been designed in Italy by the University of Pisa in Tuscany. And I think there's a lot of data already existing that can show and point this way. So these are a few of the topics that I wanted to mention. So in summary, technology needs to be co-designed from the start with patients to make sure it works properly. Treatment plan needs to be co-designed with patients. Patients need individual support and guidance to make sure they actively participate in their treatment program and also get the best benefit of them. And of course, once you have all done all that, track it, make it into a population health management plan so that you have sufficient feedback to circle back to the system and improve where needed. So thanks for your attention, and I'll give the floor back to Claire.
Thank you very much, Stefan. That was a very informative tour through some of the factors which have a significant impact on whether or not patients are adherent and how we can spot some of the patients who might be less likely to be adherent and support them. I don't have any questions specifically in the Q&A at the moment, so let's move on and see whether there are any themes that emerge that we may need some more of your input on at the next stage. So thank you to Stefan, and moving on, I'm delighted to introduce Maria Rubio-Valera, who jointly leads the PRISMA research group, which focuses on the evaluation of health technologies in primary care and mental health. With a PhD in pharmacy, Maria is a principal investigator responsible for research into health interventions, understanding treatment adherence and researching personalised interventions that could support patients in prioritising their healthcare. Her work focuses on designing, evaluating and implementing innovative interventions using mixed methods and real-world data, but also assessing their cost effectiveness. So Maria is an active member of several scientific and professional organisations in the field of public health and quality improvement, and we look forward to hearing your thoughts on the subject, Maria.
Thank you very much, Claire. Let me share my screen. Thank you for your introduction and thank you for inviting me here today. So I like to do a bit summary of the economic consequences and inequalities related to initiation.
Excuse me.
Yes.
Sorry, we do not see your slides.
Do not see my slides. Okay. Sorry. Are you seeing them now?
Yes,
Thank
it
you.
works now. Thank you. Sorry.
So the available evidence shows that non-adherence increases healthcare costs. Here you are seeing a figure taken from a systematic review from Cutler and colleagues, where you can see that non-adherence overall for all causes is associated to increased costs, and that there's a significant variability across diseases with, for example, higher costs associated to non-adherence in Parkinson's disease, cancer, or addiction. However, most evidence focuses on direct healthcare costs. That means on inpatient and outpatient care, emergency care, and the use of additional treatments as a result of non-adherence. And most of the evidence has limited information on productivity losses and other societal costs. But particularly, I'm worried about the lack of information out-of-pocket expenses. The out-of-pocket expenses, those that are directly paid by the patient at the point of use, generate an equal distribution of the negative impacts of non-adherence. Here again, this is taken from a colleague from Wilder and colleagues. They conducted a systematic review, and this is the meta-analysis results from this review. And you can see that people facing food insecurity, housing instability, those exposed to crime and violence, or those with limited transportation have higher probabilities of being non-adherent. These lower income groups bear a disproportionate burden of non-adherence because they have higher barriers to accessing medication, but also because they are more vulnerable to financial strain. And these inequalities in access to care reinforce existing health disparities. What I've been presenting so far, this evidence comes from studies that focus on secondary non-adherence. For those of you who are not familiar with these terms, here, this first patient that we are seeing in this figure is a patient that shows good implementation, taking all the prescribed pills, but that discontinues the treatment before it was intended to end. The second patient is one who persists until the end of the treatment, but that shows poor implementation. So most of the studies that have been conducted on costs of non-adherence are focused on secondary non-adherence, but that implies that the patients must have initiated the treatment. So this evidence does not take into account the economic consequences of those patients who never initiated the treatment. That took us in 2014 to conduct or to initiate the non-initiators project. We conducted two separate mixed methods studies that combined real-world data and qualitative research. One was conducted with adults and another one with a pediatric population. In both of them, we had information of around 1.5 million patients. And we also conducted interviews with 30 adults and 42 healthcare professionals, as well as with 26 caregivers and children. And we focused on most prevalent treatments for these two populations. And I'm going to summarize a little bit of our results on the impact on costs of non-initiation, on the factors that contribute to the risk of non-initiation, and also on the results of what impact have policies, co-payment policies in particular, on treatment access, taking into account the socioeconomic status of the population. So first, the impact of non-initiation on costs. I'm going to summarize the results of two main analyses. One was focused on patients who had been prescribed analgesics, antibiotics, and drugs for chronic diseases, and we checked for increased use or services after 2 years of the first prescription. And a secondary analysis that we conducted with patients that were prescribed antidepressants and that we followed up for 6 months. What we saw here is that patients who did not initiate their treatments had a higher number of primary care visits. both at the primary care center and at home visits, a higher number of visits to secondary care, and a higher number of diagnostic imaging tests. Therefore, higher costs for the healthcare system coming from those patients who never fill their prescriptions. But also, from a societal perspective, we saw increased costs, increased productivity losses, with a higher number of days on sick leave from those patients who did not initiate their treatment. Although we saw that, of course, since they were not non-initiators, the costs of drugs was lower in the long term, as well as laboratory tests. When we looked at factors contributing to non-initiation, we saw that there are some vulnerable populations at risk. In the case of adults, people at risk of, or a higher risk of non-initiation were younger patients, migrants, people with a pain-related or mental disorder, and those treated by a substitute or resident physician in training center. When we move into the pediatric population, we see that those at higher risk of non-initiation are babies and toddlers and adolescents. Those who have to copay, even a small copayment, as you can see here, from 0 to 2 euros, increase the risk of the child not initiating their treatment, their prescribed treatment. Also, there was a higher risk for children from lower income families and those who were treated by physicians other than pediatric. So we've seen that there are personal and factors related to the prescriber that are increasing the risk of non-initiation, but we wanted also to see if there were system-level factors affecting non-initiation, and we focused on medication copayment. As you know, the theory says that medication copayment reduces government expenditure, it promotes rational use of medicines, but it may create inequalities by imposing a higher burden on low-income patients. So what we did is to assess the impact of 2 copayment policies that were introduced in Catalonia and in Spain around 2012, and we checked their impact on initiation trends based on patient socioeconomic level. So the copayment policies that were introduced were first a fixed €1 per prescription copayment, and then there was a shift to income-based coinsurance that was theoretically benefiting low-income populations. What we saw is that effects varied by medication group, and that, of course, copayment measures had a greater impact on low-income individuals, but also on pensioners. What we saw is that even a small fixed copayment, the €1 per prescription copayment, increased non-initiation, and that affected particularly low-income individuals and pensioners. And we saw that impact on analgesic drugs, but also on chronic treatments. The income-based coinsurance had less impact on non-initiation, but we detected a protective effect on poor pensioners that shifted from 40% to a copayment to no copayment. And now, finally, I'd like you to explain you the results of the qualitative exploration of non-initiation based on the results of all the interviews conducted. We developed 2 theoretical models, one for the adult population, another one for the pediatric population. I'm not going to go into detail, but I'd like to highlight that, of course, the decision to initiate a treatment is complex and multifactorial, that the patient or caregiver, in the case of children, and the prescriber are at the center of the decision-making process, but we must not forget other healthcare professionals and people from the patient context that also have an influence in the decision. The models suggest that shared decision-making has the potential to help patients cope with the diagnosis and treatment, increase their engagement, and improve initiation. And this is particularly important in the pediatric population, which is more vulnerable, but also because we detected that children are not routinely involved in the decision-making process. So to summarize, all forms of non-adherence generate additional healthcare and societal costs. Non-adherence disproportionately affects lower income and vulnerable groups, creating barriers to care. High-risk groups for non-initiation include babies and toddlers, adolescents, young adults, migrants, individuals with pain-related or mental disorders, and those from low socioeconomic backgrounds. A greater patient involvement could support better treatment initiation, and protective measures for vulnerable groups are essential to ensure equitable access to treatment, understood as adherence. Thank you very much.
Thank you, Maria. A fascinating trek through some of your research there. I do have a personal question based on that I would like to ask, if I may. You mentioned a couple of times about non-adherence and non-initiation being higher in the low-income group. Do you think that is purely due to the financial concerns, or do you think it could be also due to the mental burden of managing lifestyle and household on the lower income?
No, of course, we try to running some interactions. We try to isolate the effect of the cost of the medication, of the copayment, from factors related to the probably lower health literacy and education, maybe concerns about disease, and there's a mix of things. So in the low income population, there are other things than cost of the medication explaining barriers in the access to and full adherence. But that means that in those cases, shared decision making, I think, is really, really important, because those vulnerable groups that have a lower level of education need the information regarding the disease and the medication that is being prescribed adapted to their literacy level. And even if it's necessary, as social worker interventions can be explored in primary care to help them navigate the system and gain access to medications. So I think it's a mixture of economic barriers and socioeconomic barriers understood as a whole.
Okay, thank you very much, Maria. So I think following on from that, we'll move on to our final speaker. So I'm delighted to welcome Lina Eliasson, the founding partner at Sprout Health Solutions, who specialises in understanding, measuring and improving treatment adherence and other behaviours that impact patients' health. Lina has a PhD in adherence to oral oncology drugs and a background that spans both economic research and the commercial world, having collaborated with numerous leading pharmaceutical and biotech companies across a wide range of disease categories. Before founding Sprout, she led the European Clinical Outcomes Assessment team for one of the world's largest clinical research organisations. And she's also overseen the development, implementation and evaluation of patient and caregiver support programmes. So I'm delighted to welcome Lina to give her perspective on the problem that we're all thinking about.
Thank you so much, Claire, and thank you for BMO for inviting me. I'm really happy to be here. Let me share my screen. Okay. So what I wanted to do here was to reflect a little bit on where the problem with low adherence and the impact of that origins. And I would argue that the problem really starts with the drug development process and the often limited input from the patients throughout that journey. Often the patient experience is considered quite late in the drug development, and we can see at times quite surprising administrations and sort of formulations of drugs, for example. And also we have an issue that adherence is often not measured appropriate within a clinical trial. So yes, most trials will include pill counts, but there are so many limitations with pill counts, and we're unable to use the data. It's more used as a inclusion-exclusion criteria. Is your patient adherent or not, and are they able to participate in the trial, rather than producing the data that we need to be able to analyze safety and efficacy in an appropriate way. And non-adherence, when you are looking at it, when you do have the data, it really is widespread within clinical trials, and that's something which is often overlooked. And it's also a very costly issue. So, you know, data suggests that across trial you might have, and we're looking again at the sort of initiation, persistence, and suboptimal implementation within trials is quite significant. And the problem of undetected non-adherence is that you might underestimate efficacy. You might have inaccurate estimation of adverse events in a trial setting, and you will have a much higher variability across centers, for example, in terms of your data. And the consequence then might be that you select an unsuitable dose. You might have thought that efficacy is somewhat lower and your dose is overestimated. You might end up with much higher sample sizes than you need to achieve the power that you need for your clinical trial. You might then also have an impact on patient burden in terms of recruitment. You will increase your time to market, and you might indeed terminate trials early. And you know, I have included some papers in this presentation, and I really invite viewers to go and have a look at the papers and the data that exist. But the problem is much bigger, and the impact is much larger than what is generally accepted. And so you might argue then that medication adherence is the hidden blockbuster. And this paper was looking at reasons why there were either denial or delays in approval from the Food and Drug Administration in the US for new drug applications. So drugs that have not previously been in the market. And the reasons were related to uncertainty surrounding dose selection that was provided by the pharma companies that submitted these applications, that there was inconsistent results, so across studies, across sites, across different endpoints, and that there were poor efficacy or lack of a meaningful clinical effect. And I'm not saying that this is all due to non-adherence, but what I'm saying is that the first thing you should think about, well, was the adherence in this trial? For example, if you see inconsistent result across different sites or across different population, was there a problem of adherence, or was that something else which impacted the results? And really, there are plenty of opportunities for understanding and enhancing the patient experience across the drug life cycle. So, you know, this is what we do at Sprout, and something I'm really interested in. So, you know, you have the opportunity for really early patient insights research, preclinical, understand the unmet needs, understanding patients' preferences, understanding what would be meaningful in terms of changes to their conditions throughout the drug development process, then ensuring that you have appropriate endpoints that are meaningful for patients and measured in a way that works for patients. You can also, and it's much more common now, and indeed sometimes requested by regulators, that you include embedded interviews. So having a discussion with patients about the experience within the clinical trial, how they experience the treatment, if they faced any challenges. And really, these insights can help us to produce treatments that are really addressing unmet needs for patients, but also build an understanding of the challenges that patients may face, and develop appropriate interventions and support for when those drugs come to market. So I would argue that patient engagement really is the solution to the challenges that we have with adherence, be that a personal challenge that someone experiences, or be it something which is within the system. Really, we need to start with the patient themselves and the challenges that they experience within the healthcare environment. And if you really help to facilitate proper, real patient engagement within the research setting, so really having an active, meaningful, collaborative interaction with patients as a researcher across the full process of your research. And again, be it, say, clinical trials, which is something that we do and that I work with currently, and in intervention development, then you can really ensure that what you are doing is valuable to patients. And that is how you can achieve true patient-centered care. So where care that is respectful and really responsive to individual preferences, needs, and values. And this is, you know, how we can empower patients to really be active participants in their care. And people who do a lot of research within patient engagement and adherence research will know that when I refer to patients, we refer to the patient, to the caregiver, if that is who is responsible for a patient cares, and sort of the wider stakeholders on the patient side, which are important in terms of being a user of care. And patient empowerment really could be seen as a process and a state. And so the process then of achieving empowerment is to help increase knowledge, skills, attitude, self-awareness, and confidence to engage in care. And then we can sort of reach this stage of patient empowerment. And how we can empower patients, we can do that through patient support services, and there are a range of different behaviors that are important. So yes, medication adherence is something which is core to maintaining health if you are prescribed a treatment that works for you, but also more broadly help to manage stress and anxiety in relation to your health and the way that you deal with illness, helping to develop coping strategies, so that might be for a patient or for a caregiver, and helping to maintain an overall healthy lifestyle and sort of preventive behaviors that will not only help individual, sort of the impact on the individual, but of course also help with reducing impact on healthcare systems and the costs overall. And finally, I wanted to share a piece of research by one of my colleagues, Laura Mead, and the team here at Sprout. And this research was sponsored by a pharmaceutical company, Roche, in Canada. And they were really committed to helping the hemophilia community to sort of enhance the communication, the empowerment of patients, and their decision making that was done. So for this study, went through several different stages. So started with focus groups with patients, young patients, pediatric patients and their caregivers, young adolescent patients and adult patients, as well as prescribers and allied healthcare providers that were part of the team to manage hemophilia. So that included nurses and social workers and physiotherapists, to really understand what were the barriers to having a clear and empowered communication in patients, and how can they support the decision making around the treatment. And from that, they developed the tools, and really the patients were saying that, having sort of a very strict tool to make the decision for treatment is perhaps not what we want, but really help us to equip ourselves with the knowledge, and also preparing for the interactions that we have with healthcare providers, where the healthcare providers then had prompts to really get to the patient's preferences and values and lifestyle, to ensure that they understand the options that are available for them, so that they can choose a treatment which fits best for that individual patient. And once that was developed, they went through user testing with all of those stakeholders, and there were some refinements, and then that has been disseminated. And the dissemination was done first in conference presentation, and now in a published paper, which is available for everyone to read. And I have included my favorite quote, or one of them, which is, "I can tell that this is absolutely relevant and missing in our practice." So having something like this is really good. And that was one of the hematologists that fed this back. And I know that both Maria and Stefan have also spoken to the value of shared decision making. And so I wanted to share this case study of one of our sponsors that were really committed to make this happen for these patients. Thank you.
Thank you very much, Lina. That was a really interesting presentation there. And I think what I've taken from all three presentations is the need for a more integrated view of healthcare, the products plus the healthcare system, plus the treatment selection, plus the support, with early engagement from all patients, from a wide range of patients in the design of all of those factors. And we all know that the later you make a change in a design or a development, the more expensive it becomes. So there's a good financial argument also for including the patient's decision making early. I do have some questions now in the Q&A section. One is, what is the relationship between route of administration and adherence in clinical trials, for example, pills versus infusions?
I would say it depends. It depends on the condition and the patients and how it's treated. I was thinking about some devices that I have seen. I used to work at the Hammersmith Clinical Trials Unit, which is run by Imperial. And we had a situation where one of the devices that were used to deliver a treatment was so extremely painful that nurses had to hold the patients down to deliver that medicine. And that trial was stopped, and it's something where perhaps that could have been caught earlier by really considering how that administration would have impacted patients and how acceptable that delivery method was for patients.
And the next question I have, thank you for the answer, is to all of the participants here in this webinar. So following on from the fact that everyone is aligned on the need for good patient engagement, can you elaborate on the conditions for and best practice strategies to make sure all aspects of the experience are shared and to improve the awareness and attention to subtle cues and also strategies to achieve and share understanding? So that's a multi-part question there. So feel free to answer any part of the question that makes greatest sense to you yourself.
If I may go first, I would say that in general, from my experience and studies that evolved from the non-initiation project, and where we co-developed a shared decision-making strategy, decision aids, and so on. For me, the main points are training. I think that healthcare professionals need to be, all healthcare professionals, not only physicians, need to be trained to explore the patient preferences, to use language that is adapted to the patient, and to be aware of barriers that emerge from the patient, verbally and non-verbally. That's the first thing, that our workforce is prepared and engaged. And also, second, I think we need awareness campaigns. We need to empower patients to ask for it, to go for it, to be positive when the professional explores the preferences, and also when it's not done, to ask for it, because it's the other, they are the ones that can accelerate the change, I think. And the third thing for me is to provide both professionals and patients with good decision aid tools. I don't care if it's leaflets, apps, web sources, I don't care. But both professionals and patients need these tools. These tools need to be co-designed, need to be well adapted to the patient. So it's for children. It's not the same a 4-year-old and a 16-year-old. Their worries and preferences are different. It needs to be translated into different languages. It needs to take into account the cultural background of the population you are dealing with. So that I think these three points are for me the key in achieving this change, no, of paradigm. That's my opinion. I don't know why Stefan or Lina agree with me. Hope so.
No, I don't think there's a one size fits all. I think it's important to appreciate that there are many differences depending on the disease. I think the way you listen to patient voice in people with dementia is different than childhood cancer, for instance. Totally different. But the process to go there may be similar, right? You have to listen, you have to engage with them. And one of the things that we have done with the Patient Expert Center is design services, because many of our partners, whether in hospitals or industry or government agencies, ask, we want to engage with patients, but how do we do it? And so we have designed services to design clinical trials. We have designed the processes with them each time with flow charts and different steps and task division, etc., to explain when to use patient, how to listen to them, how systematic it should be, what the level of robustness must be of listening to the patient. And so the value in that is kind of a process description that still needs to be adapted depending on the severity and the nature of the disease. But it's a way forward. It needs some education. I think specifically for medicines development, PFMD has done great work at European level, so patient-focused medicines development. And for those who are not aware, please have a look. They have a whole list of patient engagement tools that are available on their website. But that's specifically for medicines development. I think a lot of the adherence issues are, of course, not only related to the technology, but also to the way how healthcare is organized. And I think this is for hospitals and government agencies also a different step that we need to take.
Yeah, I can only agree with Maria and Stefan. And I think, thinking about this specific case study that I presented, there was a real will for the healthcare team to involve patients, but there were reasons, there was a real misalignment between what healthcare providers, how they perceived patients and what patients want and what patients themselves were sharing that they wanted. So say healthcare providers, really thought that patients wouldn't have sufficient knowledge or perhaps not the right knowledge to make a decision. And indeed, they thought that many patients wanted them to make the decisions for them, where patients weren't aware sometimes of the different treatment options, for example, that would exist and didn't feel equipped to have those discussions. And I think to Maria's point, ensuring that there is education to healthcare providers for truly understanding that specific patients group, which is what Stefan mentioned, it will differ. And also that there is appropriate information readily available for patients so that they can be equipped. And then I think also we need to really consider that different patients will have different preferences for how information is delivered and for how decisions are made. And sometimes that might differ by situation. I will have, because I also have quite a deep patient experience myself. And there were situations where I really wanted to be involved and negotiate my treatment. And there were decisions where I said, can you please just tell me what the right thing is? What would you do, doctor? I will do that. So I think just being open to adapting to individuals and what they need at any one point is important.
Yeah, and I think just to add to that, I think you have to also appreciate that within a disease, there's a lot of complexity and diversity. And there's also, again, within a disease, also not one single answer to all the different issues and problems. I saw in the Q&A that there are some questions on minority groups or people with a migration background. yes, you have to take that into account.
Mm.
I think people have different levels of health literacy. There may be religious problems. I mean, within colorectal cancer, I've come across both in fundamental Catholic but also Muslim communities that coloscopy is considered as sodomy. So there's a kind of taboo that you have to overcome to make sure people adhere to the treatment, or at least in this case, the diagnosis. These are issues that we are not always aware of. And I think it's important to understand them and to take them into account. I mean, one of our members is a Brussels-based organization of women with a migration background, because they are confronted with very often the situation that it's very difficult to talk about their disease at home. It's, you know, like gynecological cancer, breast cancer, everything that is related to typically female problems. It's not discussed. It's not even raised as an issue, and very often the diagnosis happens very, very late in the process. If it's very late in the process and the prospects are very bad, it's very difficult to have the energy and the power to adhere to the treatment. So I think this is very important also to channel people to the right places, so where they can answer questions, where they get you know, a level of comfort to feel among people who understand their specific predicament. And I think it's important for all of us to always take that into account when listening to patients and making decisions. It's the diversity of any patient organization.
Thank
I
you
think
very
it's
much.
important also thinking about minorities, that they know their rights. You know, for example, just having the right to an interpreter during important health conversations. They might not know that they have the ability to request that, and there might be many other type of support that is available, but people are not aware. So I think, yeah, making sure that there is clear guidance on the rights that you have as the patients within a particular health system or a particular hospital, I think that's also very important.
Can I add something to that? We're talking a lot about shared decision making and supporting patients, but isn't it important to take the patient perspective as a starting point? Like we said, there are different individuals approaching situations in a different way. And what I see, and this is the reason why the Beamer project is so special, because we tend to focus on personalized support, taking the patient perspective as a starting point. Usually we take ourselves as a starting point for sharing information, the level of information, the wording we use. And I believe we can do a lot better if we start with the patient perspective. And I believe Stefan already mentioned that, but I'd like to underline that. I have a question for you, Lina. In your slides, you mentioned that one of the risks of non-adherence in clinical studies is underestimating the efficacy. But what about overestimating the efficacy? Because I understand the risk of underestimation, the risk of a failed study. That costs a lot. But overestimating your efficacy costs even more. And then I'm talking about the overall economic impact of non-adherence.
Yeah.
What's your feeling about that?
No, I think you're absolutely right. The argument is that you need to measure adherence to be able to interpret your efficacy and safety data appropriately, in both directions, of course.
Thank you.
Yeah, good question.
Okay, well, we have nearly come to the end of the time here. I believe we've answered all of the key questions that have been answered, so it just remains for me to thank all of the presenters very much indeed for the excellent quality of your presentations. It's been a pleasure listening to your different perspectives on the problems around adherence and the system and how we can facilitate improvements. I would let everyone know that we will be making the presentations available. And for any of the audience who are interested in some of the references that indicate the size of the problem, please do follow up on those. And so thank you very much, everybody.
Thank you very much,
Thank
Claire.
you.
Thank you.
Thank you.